Good morning. It is Tuesday and it's time for our twice a month coronavirus virtual information session. I want to welcome everyone this morning and a very special welcome to Dr. Jon Klein from the University of Louisville. He's going to talk a little bit about research at U of L in the time of the pandemic. I will announce his topic and about what he's going to talk to a little bit later. But first, I'm giving the microphone to Dr. Furman for the update on the coronavirus.
Great. Hello, everybody, and welcome to the end of September. It's almost Thursday, will be October 1st. So we have gotten through a lot together and we'll keep getting through it. So I'm the medical director of the Traeger Institute, and I just want to kind of go over some of the numbers. So the nursing homes are testing all the staff based on the positivity rate in the county where the nursing home is. So Jefferson County is between 5 and 10%, so we're testing once a week. That's the yellow zone. The red zone is more than 10% positivity rate. And in Jefferson County, we've had 17,106 confirmed cases and 324 deaths. In Kentucky, we've had 70,636 confirmed cases and 1,193 deaths. In the United States, we've had 7,229,559 cases, and deaths in the US is 208,335. So, it's definitely here, and we have to keep doing everything, wear a mask, wash your hands, stay 6 feet away, and socially distance. Everybody needs to get their flu shot. So the flu shots are available. We have them in our clinic. You can get them at the little clinic, at CVS, at Walmart. It's your primary care provider. So make sure you get your flu shot. Schools like in Oldham County, the high school and middle school, yesterday was their first day in person, and the elementary are back. So a lot of people are going back. Jefferson County is not going back yet. So just kind of, it's added another layer of stress. So just everybody, needs to remember everybody's a little bit stressed and to show compassion, staff are, because there's more people doing things. The schools are back and things are back. There's just a lot more COVID out there. And so, people are getting sick from COVID and their families are getting sick. So I think everybody just remembers to have compassion because it's stressful. And then part of the schools being open, the governor now has a dashboard for COVID-19 cases in the school system, so you can get online and see kind of all that data. Also, just remind everybody that voting is now occurring in Kentucky. My husband and I got our ballots by mail, and you can turn them in. So, everybody's recommended people, especially for older adults, in the nursing home and personal care and assisted living at home, they want to vote. So if you could help older adults have a voting plan and you yourself have a voting plan. And I think those are my updates. I think we'll learn a lot from Dr. Klein, so he'll have some other updates and I'll be available for questions at the end. So stay safe, hands, face, space. Thank you.
Thank you. Thank you, Dr. Furman. I forgot to ask everyone to type in the county they represent in the chat. If you don't mind doing that, some of you already did that. I apologize. So as I said, I'm very excited to welcome our guest speaker, Dr. Jon Klein. He's the Vice Dean for Research and the Director of Clinical and Translational Sciences Institute at the University of Louisville School of Medicine. Dr. Klein is going to lead a conversation exploring the University of Louisville's response to COVID-19. As the Director of the university's response and planning related to COVID-19, he will share his insights on the lessons learned, the successes, and the upcoming preparations we need to do for the fall. Dr. Jon Klein received his medical degree from the University of Texas Medical Branch and his PhD in microbiology from the University of Louisville. He served his residency in internal medicine at the Kansas University Medical Center and his fellowship in nephrology at the University of Louisville. He serves currently as a director of the Clinical Translational Sciences Institute and Vice Dean for Research, and he holds the James Graham Brown Foundation Endowed Chair in Proteomics at the University of Louisville School of Medicine. Dr. Klein, you just challenged me with all these things about you, but I want to welcome you and thank you for being with us today and for sharing your insight.
Well, thanks for the warm welcome. I appreciate it. Now, I understand that these sessions are conversations, so that's why there are no slides and there's none of this unidirectional sort of teaching, and I really welcome that. Let me begin the conversation by talking a little bit about the history of the timeline of how Louisville and the University of Louisville engaged COVID-19. And I'll just sort of tip my hand ahead a little bit here, that one of the points I'm going to try and make is that a variety of investments in research that were made 10, 15 years ago actually paid off at the local level in our response to COVID-19 and to the SARS-CoV-2 virus. So let me begin by sort of reminding everyone that, you know, we first began to hear very vague reports about a new viral pneumonia in China in late December of 2019. Now, since then, we can trace it back much earlier than that, but the first public reports were right about then. And very quickly, the Chinese Center for Disease Control isolated the virus in early January and sequenced its genome, published its sequence, which, as you'll see, becomes a really crucial act and crucial accomplishment. So in early January to mid-January, the virus is isolated. And the World Health Organization declares an international health crisis. One of the things that I've learned actually after it happened was that our response was really only about 28, 30 days after those events at the University of Louisville. That Dr. Kenneth Palmer and the Center for Predictive Medicine, because we had built many years ago, 15 years ago, a biocontainment level 3 laboratory that can handle the most dangerous pathogens. He was able to then request aliquots of the virus. He was also able to take the genetic sequence and begin to develop a PCR test to diagnose. So our entry into this really begins in February, before the rest of the country is really very much aware of COVID-19 and the SARS-CoV-2 virus. And from now on, I'll just use those two terms interchangeably. So the first cases in Louisville are somewhere around March 3rd, March 4th, as best we can tell. And at that point, the earliest research actually begins then, and that's clinical research as well as basic research. The clinical research that begins is led by the Division of Infectious Diseases, and they have an institute that really a center, which is called the Center for Excellence in Infectious Disease Research. And they begin to work on their relationships with hospitals throughout Jefferson County, which they had developed over many years. They have studied a variety of infectious disease problems, and they had built very strong relationships with the medical directors of all the hospitals in the county. And so they begin to actually connect with Dr. Palmer's group at the Center for Predictive Medicine, and they develop the first test in Louisville, the first nasopharyngeal, or sometimes we call it the brain tickler test. And that begins the first testing. We can begin to identify people in the hospital who are positive for the virus. And that's probably the first clinical work that was done by the university, as well as the first research begins. And since that time, I think you've all read about a number of other things that the university has brought forward, everything from developing new therapeutics, that's both Dr. Palmer as well as Dr. Paula Bates, are testing an antiviral agent that will be used as a nasal spray. That was funded, and the grant was actually, I think, activated last Friday to begin this nasal spray preventive test. That's a Department of Defense grant. Dr. Bates has taken an anti-cancer drug and shown with Dr. Palmer, using the facilities at our BCL3 lab, to show that this anti-cancer drug actually can block the entry of the virus into cells in culture. And then finally, more recently, I think most people are aware of the Co-Immunity Project, which is led by Dr. Bhatnagar, myself, and Dr. Palmer, where we've done testing of healthcare workers as well as the general public. So there are really two phases of that in terms of testing people. There's testing healthcare workers. Most of those were within the U of L healthcare system. And what we showed was that there was a very, very low incidence in the beginning of active virus, and actually a lower incidence in healthcare workers than in the general population. And the same thing goes for the presence of antibodies or seropositivity was much lower in U of L healthcare employees, physicians, nurses, everyone who volunteered from the healthcare system. It was actually much lower than in the general population. However, we've now done that testing several times. We're on our third go round, I believe, that will be coming up in October. And what we see is that it's rising, but not to the same degree as the general public. The general public, we actually had two cohorts there. There was a self-referred cohort, and then we also had people who were approached by letter and was randomized. Really, what we ended up with was a good cross-section of the county, really adjusted for everything from age to sex to zip codes. And so we had a really good picture of the county as a whole. And there we see that the seropositivity is rising, but it's really still quite low. We are nowhere near what would be called community immunity, or sometimes referred to as herd immunity. So those are sort of the major research projects. There are others that are going on, but I wanted to lay those out for the group. And so sort of in summary, we have the initial projects, some of which were basic science projects that showed that various compounds could inhibit the virus in cell cultures. We also have clinical studies that are about to begin of antiviral agents that are preventative, and those will start in the next few weeks. And then finally, we have the Co-Immunity Project. Co-Immunity Project initially was going to be 2 phases, healthcare workers and then the general public. Now it's expanded to 3 phases. We're doing so-called wastewater testing, where we're looking for the virus in various water treatment plants around the county, and looking in sewage to see the presence of the virus. It appears, based on the literature and our own experience, that the viral counts will rise in sewage before we can detect them in a patient population. So it's a very valuable screening tool that can also have spatial distribution. So we can tell that this zip code or even this neighborhood eventually is beginning to see a surge in viral counts. And so we need to focus some testing efforts in that area. And then finally, something that we're doing in conjunction, really a large collaboration with the Traeger Institute, is we are moving towards developing a cohort of follow-up patients, people who have had COVID-19, and we have particular interest in following the long-term consequences of the disease in terms of involvement in terms of their cognitive ability, their hearts, their lungs, their kidney function, basically all the organs that have been shown to be affected by the virus. We're very excited about developing a long-term cohort that will be followed in a specialty clinic. So I'll pause there for a second and tell me, how are we going to handle questions and discussion here? Are we going to unmute people or text messages?
Yeah, what we normally do is we post any question that anyone may have, can post in the chat, and then I will read the question and you can just respond. And then, we can also, if someone wants to ask the specific question directly, they can do so as well. But everyone is muted right now, so you have to ask Justin in the chat to unmute you if you want to say something.
Well, let's see. Are there any questions yet in the chat?
Yeah, so I have a question. My question relates to what's your feeling about how we need to prepare for the fall? If you know, think about it, everyone is saying in the summer, be outside, is safe and all of that. Now people are moving inside, you know, because of the weather, and our numbers are high. And it's like, to me, there's almost a discrepancy in my head. You know, in March, everything closed down. There were not that many cases. We have so many cases right now. So, you know, much more of an issue, but everything is just going on. And what kind of role should we play individually to protect ourselves and protect others?
So this is a question I've been hearing in the last 5 days, 7 days, with increasing frequency. If we look at the national daily positive rates, or the daily positive tests, it really appears that we are re-entering an accelerated phase of the pandemic. Numbers are increasing in approximately half of the states. Positivity rates, seropositivity rates are increased, but also the percentage of positive tests, which is a real tripwire, a real early warning system, is rising in almost half the states. This is focused to a great extent on the Midwest and particularly North Dakota, South Dakota, Utah, and Idaho. We're beginning to see spread that is accelerating. So what are the tools that we have at our hands? And they're really the same ones that we had back in March as far as prevention. Prevention is really very much based on social and so-called physical distancing, 2 meters, 6 feet minimum. Particularly more I will try to achieve if I'm indoors, simply because the possibility of persistent aerosols is present. Mask wearing, I've really just advised my patients as well as my family that just get used to the mask and use them when you cannot social distance, is what the recommendation is from the CDC. Well, personally, I just even when I can socially distance, I'm wearing my mask. And then finally, we put a lot of emphasis in the early parts of the pandemic on surface transfer. That does not appear to be as much of a risk, but certainly hand-to-hand transfer, so hand hygiene is still very important. These are very simple things, and we keep hearing them, but I think it's up to physicians and other caregivers to emphasize that these are the tools that we have at hand until an effective vaccine is available. And then as far as treatment, we've seen some real progress in treatment in the last 6 months, and we can go into that if you'd like, but while there's progress, it's still a limited number of options that we have. And so I think that the autumn is here, the risks are greater, and there are signs, perhaps because we're 2 weeks after Labor Day, perhaps because we're more likely to be indoors in northern latitudes, but it definitely is time to sort of re-emphasize and redouble our efforts in distancing, masking, and hand washing.
Mm-hmm. Thank you. There is a question in the chat that's asking when treatments show any promise in culture, what is the timeline to test it in human subjects?
Not short enough is the answer that I have, is that most of the agents that are shown to be efficacious and to be, really effective in culture, you're looking at a timeline for most of them that's really a year to 2 years, and in many cases 3 years. One of the really interesting things about Dr. Bates's compound is that it's already been tested in humans as an anti-cancer agent. So it will jump faster into phase 1 trials, and it's been licensed by the university to a company that is moving towards phase 1, which is basically safety trials, not efficacy. So for most of the compounds that work in culture, 2, 3, even more years. Fortunately, there are a number of compounds that are both antivirals as well as anti-cancer agents that have already been tested in humans. Probably the best example of that is remdesivir, which we're giving to patients, which was developed as an antiviral for other viruses. There are a large number of antivirals that were developed for SARS-1 as well as for HIV, which are jumping immediately into human trials because they've already been done in other trials and actually were shown not to work in previous agents or in previous studies rather. But then there's some hope that they may work here, just as remdesivir has some limited efficacy to shorten the length of time that people are in the hospital and on a ventilator.
Mm-hmm. Thank you. So Colby is asking, can you talk about the effects and risks of flu occurring at the same time as COVID? Not just in an individual, but as it affects a population being in the community at the same time.
So I'm going to be very careful about talking about public health because I'm not a public health expert like a lot of the people who are on this call. Background is in microbiology, so I understand the virus reasonably well. But I've kept my ear to the ground, so to speak. And so let me try and answer that to the best of my ability. There's great concern among people who set policy and then in the caregiver community about what will happen if we have a really serious flu season. We see the number of hospitalizations go up every winter and actually from autumn to spring in elderly in particular, patients who have influenza. So while we all know that the influenza vaccine is not perfect, does not cover all infections, we also know that it's useful. And so we're really recommending that all of our patients get their vaccine who qualify for it or who appropriately should receive it. There are a few people who should not receive it. To be honest, the news from the Southern Hemisphere, which has just come through its winter, is encouraging because they had a very mild flu season there. And so the real public health experts are trying to figure out, well, was this mild because of the COVID protections that were taken, of distancing and masking in particular, and hand washing? Or is this simply a milder influenza virus? My bet is that this is because we are taking the sort of precautions that limit spread. And hopefully we'll see the same thing here if we continue to practice the measures that we've tried to encourage people to practice since early March. So influenza, absolutely very pro, get your vaccine. If you're qualified for the extra strength vaccine because of your age, please get that one. Everyone who is certainly has an indication for the vaccine should get it. And really, we should be in vaccination time already right now. I haven't had mine yet because I'm in the Pfizer COVID-19 vaccine trial, so they don't allow me to have mine until 2 weeks after my last injection. But if you're not in a trial, or if you don't have a medical contraindication, by all means, we should all get our flu vaccine.
So that's good advice. Justin is asking, how do these treatments potentially differ from vaccines in terms of efficacy and safety side effects?
Big differences, and for most of them, we won't know a great deal about efficacy until after the phase 3 trials are completed. A lot of the ones I've spoken about, so the compounds that are being developed at the university, are preventive agents as well as therapeutic. So they're being tried as certainly the compound that comes out of Dr. Palmer's lab is called Griffithson, and it is used as a nasal spray to prevent the infection. And so this is a Department of Defense study. Presumably people who take the compound would do a nasal spray once or twice a day, and that would be a preventative agent. Some of these have already been used in a variety of settings, like I've said before, so we know what the side effects should be, but we don't know the efficacy yet, and that'll take another, easily another 12 months to really know about efficacy of the compounds that are coming out of the university.
Mm-hmm. Christian, you want to ask your question? Just take off your mute.
Very good. Sorry. Great. So yeah, I think infectious disease department has partnered. They have a contract or something with Pfizer or Eli Lilly or something. I think they're starting to do monoclonal antibody as treatment in the nursing homes. And I was wondering if you'd heard much about that.
So I know about the Lilly product. I was not aware infectious disease was beginning a trial. I thought they were trying to set it up, and that's fantastic news. So what Eli Lilly and a number of other companies have done is study antibodies produced by people who successfully cleared the disease. And then they characterize those antibodies, literally some of the studies at the atomic level, one atom at a time in the antibody. And what they've done is selected those that had the highest neutralizing, which is to say killing ability, so the most protective antibodies. And then they've begun to produce synthetic forms of those antibodies. So this is not serum from patients. This is serum that was studied. The best antibodies were selected, and then they were synthesized. And this is going to take until the end of the calendar year to know if these actually are effective. The first round of studies from Lilly looked very encouraging. They definitely attenuated the disease in a limited number of patients, but that was really a phase 2 study. We need the phase 3, which sounds like what our infectious disease group is doing. That's fantastic news. These are really promising treatments.
That's really great. Yeah, they just approached us because, we have like 3 or 4 nursing homes, and so trying to ask us to get our nursing home. So yeah, it sounds like we're going to do it, and they'll send in like 10 to 15 people once you have a person that has symptoms. I think it's symptoms. They want you to have symptoms. I don't know, it's all the details, but yeah, I'm impressed. It's happening. So that's really, really good.
So this has taken about 6 months from start to this point, maybe a little less, maybe 5. So this is tremendous, speed. We're experiencing something that I like to say we've never experienced before, and that is we are watching science in real time with all of its warts. But we're also watching it in real time, moving faster than I've ever seen it move in my entire career, and that goes back 35 years. So this is very exciting. The other thing about antibodies is that's interesting is that initially they're being tested as treatments, but as they scale up the production of these synthetic antibodies or synthesized antibodies, the supply will eventually reach the point where a different sort of strategy will emerge that will absolutely involve people at the Traeger, because once there's a lot of this antibody available, what we'll see is an index case in a nursing home will be identified, it will be treated, but then the other patients will receive the antibody as a prophylactic measure. And that's been stated by Eli Lilly and these other companies since the beginning, that they intend this to be not only a treatment for the disease as well as a preventative for the disease. And in their own literature, their press releases primarily, they've spoken about, in particular, nursing homes and then other congregate areas of vulnerable populations. So I think this is really exciting news. I'm excited to hear that the Traeger is going to be a part of it.
Yeah, thank you. That was really helpful.
Okay. Yeah, thank you. Joe is asking 2 questions. I'm going to start with the first one. Although we are taking precautions, how can we ensure safety at home when family members are out and about, hopefully wearing masks, but taking them off to eat with friends or family?
Well, which Joe is this? Is this my friend Joe?
Joe D'Ambrosio.
Yeah, this is my friend Joe. You're asking a very good question, Joe, and unfortunately the answer is you can't be sure. That's some of the stress and this anxiety that we're all living through. Is I know what my exposures and risks are, and as a caregiver, we all do. I don't know my adult children exactly what their exposures are, and they want to come visit. So these are all stresses that are in our lives. One of the sort of the exit strategies from that anxiety is broad-based, home-based testing, and that is not yet a reality. And you know, allow me to say this is that the testing situation is not anywhere close to where it should be, both at the university as well as in the entire community. It's better than it was, obviously, in March. But there really has been virtually no guidance from the federal level about testing. And what there has been at times has been in conflict and to me personally confusing. There was an announcement yesterday that 150 million of the Abbott Labs point of care antigen tests are going to be distributed. There wasn't a lot of detail. We would hope that a lot of those would go to long-term care facilities and be made available to general congregate housing. But we don't have that guidance yet from the federal government. That to me is the answer to this sort of anxiety about, well, where are my kids? Where's my spouse going? Where's my partner going? I think if I had the ability, if all of us had the ability to test 3 days a week, 4 days a week before we head out the door, even given the limitations of those tests, which do have more false negatives, if we were able to test 3 or 4 times a week, that would have a tremendous impact on the spread of the virus.
Thank you. Next question, difficult one. It's conspiracy theory question. So a bacterial disease, brucellosis, which causes headaches, fever, and fatigue, Malta fever, has recently been leaked by a biopharmaceutical factory in China. What are your thoughts on other pandemics occurring over the coming years?
You know, I have to tell you, and I'm not going to answer the question directly because I have no real knowledge about that. But back in 2002, a friend of mine, and some of you may know her, Karen Bloom, who used to direct physical medicine and rehabilitation over at the Traeger Institute. Her father was a very well-known infectious disease doctor, really one of the top recognized people in the United States. And I met him and he said, you know, I'm working on this thing that's going to cause a pandemic. And I thought, really? And he was working on the original SARS-1 virus. And it spread initially in poultry populations. And he said unequivocally that there was going to be a worldwide pandemic eventually. It might not be this virus, but there would be other viruses that would make the jump from animals into humans. And he was absolutely certain of it. And that was a little after the year 2000, 2001. And I listened to it, and I have to admit, I just filed it away. I forgot about it. And when we first heard about the outbreak in China in December, I thought about him. Because within days, we knew that this had jumped from animals to humans and that it had never been seen by humans before. Seen in the sense we had never encountered it in our immune systems in this aggressive form. So early on, I remember Dr. Bloom talking about this, and I think that we will see more potential pandemics. Hopefully we have learned so many lessons from this one as it plays out over the next 2 years that we build infrastructure, and in particular, we reinvest in public health, because in the United States, we have disinvested in our public health departments over the last 20 to 30 years. And that's one reason that we're suffering so much right now, in my opinion. So I hope we learn some very, very important lessons. I'm not convinced by any of the theories that this particular virus jumped out of a laboratory in any country, including China. The data are not particularly convincing so far. But you know what? At this point, it doesn't matter. Wherever it came from, whether it came from bats in the south of China or whether it came from a laboratory, which does exist, a very sophisticated virology laboratory in Wuhan, it does not matter to me. What we have to do is just deal with it and protect the most vulnerable among us.
Thank you. Colby is making a statement and then asking a question. He's saying, to be clear, the risk the virus presents in public places and where people gather is not lower currently than it's been at any time since March, right? It is actually higher concerning sport events, particularly indoors. So can you comment on that?
So if we're talking about the infectivity of the virus, its ability to spread from one human to another, that's one of the most interesting things about this virus to me, and puzzling, because most of the spread will come from individuals. We believe that they have very high viral levels. And there are a lot of people who are infected who don't seem to spread it, even in their home, even at close quarters. So we can't just say it's all about 2 meters, 6 feet, because some people are obviously sleeping next to one another. And probably the best example is our mayor. His wife had the disease and he did not. That puzzles me tremendously. So there's a great deal that's unknown about the spread. I think that we are seeing an upswing that will rival March in terms of the number of states that are involved and where our daily positivity rates get as we head into this. But I'm not certain. This is all educated guesswork, and there are people much, much better qualified than I to try and predict this. The Institute for Health Metrics out in Seattle has been at the forefront of trying to predict what's going to happen next. And to be honest, they haven't done a good job. They have not nailed this. And there are a number of other institutes at Harvard, the World Health Organization, who are trying to predict what's going to happen here in the fall. And I think if they get much beyond 3 to 4 weeks, they're on shaky ground as far as the prediction, because people change their behavior. When things look good, people naturally tend to loosen up. When things are scary, people bear down again. So it's the human element that is impossible in some ways to predict, despite our best efforts. And I think that that's really sort of the most difficult thing to try and manage, if you will, is the sense of social cohesion. Is the idea that I wear a mask to some extent, a very minor extent, to protect myself. I wear a mask to protect you. And that sense of social cohesion seems to be stronger in some countries and weaker in others. And here it appears to be weaker. That's my opinion.
I agree with that opinion, by the way. So someone is asking, I've heard that testing swabs should be used at a horizontal angle rather than straight up in the nose in order to accurately reach the nasopharynx. Oh, I'm so sorry for these words that I can't even say. It's because English is my second language. Rather than straight up in the nose in order to accurately reach the nasopharynx, and this may be skewing results. What are your thoughts on this, please? I'm sorry, I couldn't say that word.
Oh, yeah, actually, I've got that, and this is an excellent question. There are not very many studies that compare nasal swabs versus nasopharyngeal swabs. So nasopharyngeal swabs are what I like to call the brain tickler. I've had those done. They are less pleasant than nasal swabs, obviously. There are a couple studies that seem to indicate that nasal swabs have more false negatives, and that the nasopharyngeal swab is actually more reliable. One of the problems that we've had, and once again, this comes back to the sort of the lack of a national programmatic approach to testing, is that the longer swabs are still in short supply for nasopharyngeal testing. And so there's a scramble every time there's a flare somewhere to find those nasopharyngeal swabs. The nasal swabs, well, yeah, those are in plentiful supply. And so in some ways, it's the supply of the infrastructure or the testing equipment that is limiting and guiding the way that we do the test. And that's bad science. That's bad medicine. Mm. The other thing that's interesting is that saliva testing is becoming more and more common. That would end this issue of what type of swab to use. The initial studies from Yale indicate that saliva testing is equal to nasopharyngeal, to deep nasal swabbing. It's very preliminary, limited numbers of tests. So I think it's important to see the larger numbers as people begin to embrace saliva testing. We're beginning to position ourselves to do saliva testing at the Center for Predictive Medicine. And I think one of the things we'll do in the beginning is parallel testing to certainly benchmark it against nasal swabs and hopefully benchmark it against nasopharyngeal swabs.
Joe is asking, would you recommend that we get COVID testing even if we do not have symptoms?
I think that certainly if you think that you've had an exposure, let's sort of clear the air. The CDC has been, uncertain about this. I think they were right the second time they issued a statement, not the third. I think that if you've been exposed, you feel like you've had an exposure and you're asymptomatic, or if you've been around someone who's positive that's a relative, I think testing is important. I think it's, we know that at the time of testing, somewhere between 20 and 40% of people who are positive will be asymptomatic. There's now some question that that's really pre-symptomatic, that many of those will go on to get symptoms. But we know that it's possible to walk around with the virus for probably the first 5 days that you're infected with no symptoms. And so it's very important, if you think that you've had a risky exposure, that you should be tested.
Dr. Furman, where do you recommend patients without insurance go for a flu shot? What is the approximate cost?
And maybe other people on the call might know this for sure, but I think the health department gives free flu shots. So I would check with the health department first. John, I don't know, do you know for sure if the health department gives free flu shots?
No, I don't.
I don't know. I think call, and maybe other people, on this call would know. And the cost of a flu shot, I am not sure about that either. So I apologize. I can look that up and get back to you for sure.
All right, we have a next question from Pam.
Yeah, maybe $7 for a flu shot,
go ahead.
but yeah.
Okay, so Pam is asking, can you share a little bit more about sewage testing? Is the data public? Is this happening at the university currently in the dorms?
I don't think it's happening at the dorms. There are multiple sites across the city, across the county that are being tested twice a week. It's like most things, it's much more complicated once you get into it than when you thought in the beginning, and so there's a variety of things that have affected the results that are still being worked out. Everything from sewage flow rates to of the sewage, because we're in the middle, or we were in the middle of a drought. And when there's a drought, everything slows down underground in our sewage system. When there's heavy rain, the rain comes right out of the water catchments. And if it's very, very heavy rain, it'll spill into the sewage system. That's one of our big public health issues that they're spending billions on at the MSD to solve. So the city is getting the data. They are trying to align it with testing. And there's some indications that it's useful. I don't know if there's a dashboard yet up at Sarah Moyer's website at the Department of Health. I haven't checked in the last several days. But I know that they are getting the results twice a week, and they are trying to overlay them with the testing on a sort of a geographic spatial distribution.
Mm-hmm. Okay, then from Dr. Furman, do you think scientists knew we should wear masks at the very beginning of this virus, but because they did not recommend it because we did not have the supply, and they wanted to use the supply for frontline workers?
I don't know if that was policy at the national level. I know that many people that I spoke with in hospitals, when we really had a shortage in March of particularly N95 masks, were adamant that they wanted caregivers to have the PPE that were available. This is one of those utilitarian decisions that people were making in early March based on a sense of crisis that I think was real. And the idea is that if the healthcare system collapsed, then the pandemic would get much worse. So I think that that's plausible, but I don't think anyone ever issued a policy statement from the CDC saying the reason we're not recommending masks is because we want to save those for caregivers. I think it's likely that was some of the thinking that went into it.
Mm-hmm.
Just my opinion.
I have one more question. Right. I have one more question. Can you speak a little bit about the use of ventilators during treatment? There seems to be a move a little bit away from the use of ventilators. What's your thoughts on that?
So when we go back to March, a couple things, I don't know how to say this in a nice way, but we truly were groping in the dark. And to some extent we still are, but back in March, I was rounding in the hospital and took care of people, who had COVID-19 and were extremely ill. And based on our usual approach, we intubated and ventilated people based on their oxygen saturations and their blood gases, or the sense that they were fatiguing and could no longer really breathe adequately on their own. And one of the things that was noticed was sort of this lackadaisical hypoxia, that people would have oxygen saturations that were not normal, but behave normally. We, meaning physicians, nurses, other people in the hospital, would still put those individuals on ventilators. And then as they progressed, the ventilator settings were adjusted to increase the pressure to keep the lungs open, the alveoli open. That caused, we think, some degree of what's called barotrauma to the lungs. And so one of the lessons we learned was if you can avoid ventilation with endotracheal tubes and a standard ventilator, if you can use BiPAP machines, if you can modify home CPAP machines that can keep people oxygenated without being ventilated with the associated barotrauma, that it was a good thing. And so we've become more conservative about intubation, more conservative about ventilation. That said, some of the lessons we learned also in March involved just positioning of the patient on a ventilator. And so the so-called proning technique, which in adult respiratory distress syndrome had been recognized by time that putting putting people face down and proning them while they're on the ventilator improved oxygenation. So not all of this is molecular biology and high-powered science. Some of this is old-fashioned clinical medicine and sort of using lessons that we learn from other forms of respiratory distress.
That's very interesting. Any more questions? There seems to be, I think we've handled all the questions in the chat. Is there anyone else who wants to ask a question for Dr. Klein? Seems like we're at the end of the hour almost. I just want to remind everyone that the next session is going to be about voting during COVID-19. That will be in 2 weeks from now. And I just want to thank Dr. Klein for his discussion with us, for the way in which he talked to us. It was very insightful. I really appreciate it. And I'm almost certain everyone on the school do as well. So thank you. And we really appreciate the time you spent with us. And then Christian is just, yeah, she's just saying, make sure everyone register by October 5 to vote. Please vote.
And thank you for having me.
Thank you. Thank you. I appreciate the time with you. Bye.
Bye-bye.